am happy to introduce Dr. Gabriel Wardi, who is a board-certified emergency physician, cross-trained in internal medicine, critical care at University of California, where he's an associate professor in the Department of Emergency Medicine and Division of Pulmonary Critical Care and Sleep Medicine. He is the founding chief of the Division of Emergency Critical Care within the Department of Emergency Medicine. And the major focus of his career thus far has been on improving the diagnosis and outcome of sepsis patients. He's the medical director of a hospital's sepsis at UCSD since 2018 and has overseen a 40% drop in sepsis mortality during this time. He's been funded by NIH and the Gordon and Betty Moore Foundation to investigate novel approaches to improve care of patients with sepsis through big data and machine learning approaches.
All right, am I good to go?
You're good to go, Dr. Wardi.
All right. Well, first of all, thank you, everyone, for being here. There's a number of familiar faces, so to speak, I recognize that are on the Zoom. And if you do have questions, feel free to put them in the chat, and we can get them answered. In terms of disclosures, as you heard, I am funded by the National Institutes of Health. I'm on a K-23 right now. And I also have received consulting fees from Abbott Laboratories, although everything we're talking about is independent of anything I've discussed with Abbott. I also do want to say a giant thank you to my mentorship team here. I see one of them is on the call right now, Dr. Malhotra, and there's Dr. Damati as well. But I think between those two and Dr. Chris Longhurst here, they've really done an amazing job of putting me in a tremendous situation to succeed over the past 3-4 years. And I just really want to, since two of them are here, just to tell them how grateful I am about all the work they put in with me. And it looks like the third one has just joined too. But tremendous thank you for putting up with me, for going over all the grant proposals that I put in. Your mentorship has truly been invaluable. And I also did want to thank ACTRI. This was something that I put a pilot grant in probably about 3 or 4 years ago related to COVID that was funded, that actually some of that data was then used for my K-23. So again, a giant thank you to ACTRI as well. And really, as we go through this, there's probably 2 major objectives that I want to cover with everyone here. But there's also a lot of what I've realized is, particularly clinicians and people who are not data scientists, don't have a lot of experience with machine learning. And it's still kind of this black box that you hear about this all the time, and there's not a lot of understanding of what really goes into that. With that being said, though, I think probably the major thing I want to highlight is some of the work we've done with the development and, more importantly, the implementation of a novel deep learning model that we use now at UCSD to predict sepsis. And what we're going to go through is kind of illustrate the creation of this model and how it's impacted patient-centered outcomes at UCSD, and then highlight some of the newer directions that we're moving on that I think will be very, very beneficial for really giving us some of the best possible patient outcomes here. I also like to start out any talk where I discuss sepsis with a reminder to everyone of why this is such an important topic. By the numbers in the United States, it's estimated there's more than 1.7 million people a year who develop sepsis, and of those, roughly 350,000 die each year. The economic impact is tremendous. It's probably the most expensive condition that's treated in the United States, with estimates of more than $68 billion a year that go into either the direct management of sepsis or some of the sequelae of it down the road. And as you can see here from this figure that I still keep in all the talks I give, because I think it's been pretty spot on, we really are seeing a significant rise in the number of cases of severe sepsis and septic shock in the United States. That's probably a function of an aging population, but also more and more patients are surviving their initial hospitalizations, and really kind of a perfect setup for developing sepsis down the road. Now, if you're curious about the global burden of sepsis, well, this is where we talked about 1.7 million cases in the United States, but if you go worldwide, it's estimated there's about 50 million cases of sepsis a year. And of those, roughly 20% of people die. from sepsis. And it really, I think that number just really illustrates to me how we have an unmet need in terms of optimizing care of sepsis patients. What we're not going to talk about too much today that I think is finally getting some attention, though, and I think, again, it's a perfect example for machine learning to really kind of jump on to improve down the road effects. So as we realize that even if someone survives their initial sepsis hospitalization, the long-term effects there tend to be quite debilitating and can last as far as a year. So it really is something that if we can get someone over that initial hump, we then need to meet their care down the road to really ensure that they get appropriately launched, to make sure they don't end up back in our hospital a few weeks after they've been discharged, to make sure their recovery goes down a nice, smooth pathway. I think something else worth highlighting, and I know there's a number of researchers here, and they're probably asking, well, what are we doing very specifically for sepsis right now? This is going to be the National Sepsis Policy that's been put forth by CMS, and it looks relatively simple. And for a condition as heterogeneous as sepsis, a lot of people say, yikes, that's all that the federal government can come up with to kind of hold our providers accountable. And the truth is, yes, this is what what our federal government has put forward as these bundles that are recommended to improve care of patients with sepsis. Now, we were fortunate enough to recruit someone from UCSF, Dr. James Ford, who's on the call, and he recently worked with me, and we actually did a relatively extensive systematic review where we kind of highlight some of the downside, so to speak, of kind of forcing people to comply with this bundle, highlighting that it's not really that evidence-based. But again, this is what a lot of times people will jump on in terms of sepsis management. With that being said, too, I do kind of want to tell the story of how I got interested in sepsis and some of the work that we've had here and how that's impacted patient-centered outcomes. And what I'm going to show you is I finished my fellowship at UCSD in critical care in 2017, and I took over our hospital sepsis committee in 2018. And you can see here, these are some of the baseline data that we have in terms of our observed to expected mortality here. And it became, honestly, a privilege to work with a number of extremely talented individuals about how we could improve the outcomes of our patients that have sepsis. And I'm going to illustrate that through some examples about how we go through this presentation. I think one thing also that whenever I give a talk on, that involves artificial intelligence, definitions and applications, that there's a wide variety of what people think about this. I remember when I was telling one of our emergency medicine residents we were working on a machine learning approach to improve sepsis outcomes. He asked me if we were effectively creating an Arnold Schwarzenegger Terminator type individual that was going to walk around the hospital and ask people why they weren't giving antibiotics and why they weren't giving fluid boluses. And I think at that time, this was probably about 3 or 4 years ago, it really illustrated to me that there's a lot of misunderstanding about what goes into these AI topics when it comes to people that don't look at this every day about some of the potential benefits, but also some of the things that we're just not quite there to implement into clinical care, because we do not have any Arnold Schwarzenegger type individuals that are walking around our hospital wards right now, kind of demanding that people comply with sepsis care. I think something else that I've always been very intrigued by, particularly in this era right now, is this is a picture of Thomas Kuhn. And when I was an undergraduate at Georgia Tech, we had to read The Theory of Scientific Revolutions. And I think right now that we're probably at the point where, with the way that we've approached data science, with the capabilities that we have right now, that we're now at the point where we really are full on in a scientific revolution. And really the question is, how can we use a lot of these principles to better the healthcare that we're administering to people? And we're not, obviously, there's still many, many things that need to be hammered out. There's still lots and lots of unknowns, and there's still a lot of technology to grow here. But I do think that we're at that point now where we're starting to really kind of enter this revolution head on. And it's been a real privilege to work again with some of these people, some of the people on this call right now, to kind of see how we could use these principles to move forward. I think something also that I remind people, if you are scrolling on social media right now, that anything you're probably looking at is going to be heavily driven by some type of machine learning application that is very, very ubiquitous in this domain. And honestly, a lot of places that we go, why we get what we get when we open up any kind of application on our phone or outside of that is driven by some kind of machine learning model that usually gets pretty darn good at actually understanding what we want to see based on the prior history of how we followed things. So it is something that I think is always to me has been fascinating, why machine learning approaches artificial intelligence has been grasped so rapidly by a lot of different industries. But in the healthcare field, we're still not quite there with the same enthusiasm. So we're going to talk a little bit about the lingo. And again, this is, one of my colleagues called me yesterday and he said he reviewed a machine learning article and he didn't have a lot of experience there. And I said, probably one of the best things you can do is just a good understanding of what are some of the terms that the authors are using. And I know that some people here might be world experts when it comes to machine learning. They are literally writing the textbooks that people are following, but probably a lot of you have heard some stuff, but don't have kind of crystallized definitions. And I think it's going to be germane to understanding some of this talk to understand some of the lingo here. So I'm going to throw out 3 definitions we're going to look at. The first one is artificial intelligence. And the way I'm going to define this here is describing automated systems that can perform tasks that are considered to require quote unquote intelligence. It's an extremely broad field. And of that, we're going to take a subset of that called machine learning. And the definition I like, and again, I think this is a pretty solid one, is the process of developing systems with the ability to learn from and make predictions using data. Now, this is an older term, and we'll talk about some examples of that on the next few slides. But really where people have gotten very, very excited now has to do with what we call deep learning. And deep learning is a subset of machine learning that uses multiple layers of arithmetics to make a final prediction. You can see an example here on the right of an artificial neural network that has inputs and there's multiple layers before an output is achieved. And that is going to be what makes deep learning. And taking advantage of the vast amount of data that are now available in our electronic health record, but also with the computational power to actually perform these computations, you can do some really, really special stuff. And just as a brief example, again, just paving the way for the rest of the talk down the road, so to speak, is this is what these artificial neural networks are based on. It comes from humans, right? Taking a look at the neuroanatomy, you can see that each part of the brain, when it comes to the visual cortex, has a specific function that it does. Everything is then summed up, and that's how we're able to recognize something like a face. And this is what we're trying to approximate when it comes with these artificial neural networks, is each layer has a specific task that it does, and then it passes that data on to the next layer. And again, it's these multiple layers are what make a deep learning model. And then the output then is going to be, in this example, some kind of object identity. But again, the underlying driving factor for this, it's driving on how our human brain works, these neural networks that we have there. Again, the last little part here before we kind of jump into some examples here has to do with some of the machine learning applications that are pretty prominent right now in the medical literature. Probably the one we're going to talk the most about is what's called supervised learning. And the distinguishing characteristic here is that we have labeled data or data that is labeled both on the input and on the output. And this can become quite useful, as I'll show you in the next few slides. And there's another approach called unsupervised learning, where effectively you can think about this. You have a bunch of input data that's labeled, and the model then finds similarities between the input data and can use it to cluster outcomes. So what might this look from someone that studies sepsis like me? Well, one of my mentors that's on the call right now, I think at this point still has one of the most cited papers in machine learning and sepsis out there. And this was an example of supervised learning where they had the input features, which would be things like vital signs, lab results, medications that have been administered to patients, but also the output, which was sepsis. And they trained the model to take the input features to guess which patients in the ICU had sepsis. Again, with both input and output data. Really, and we'll dive into this a little bit further as we go on. I'm going to contrast this, though, with another example of something that got a ton of press in the literature that was put out in JAMA in 2019, which was some work from the group at Pittsburgh, where they were able to use an unsupervised machine learning model that clustered sepsis patients into different phenotypes. And what got people so excited about this is that they were able to show that one of the phenotypes actually had worse outcomes with fluid resuscitation that we've, again, assumed has always been a cornerstone of the management of sepsis patients. And again, what made this unsupervised? Well, they just had input data, and they allowed the clustering model or the clustering algorithm to kind of differentiate all these different input patients, and it let the model kind of choose the output, so to speak, and that's what we got these phenotypes from. So again, just two big examples of probably some of the most well-known examples of both supervised learning and unsupervised learning in the machine learning literature of sepsis. So I do want to kind of explain to everyone how we got to our model that we use right now at UCSD before we jump into how that actually improved patient-centered outcomes. And again, this is one of the papers that I just showed up here. And this was a supervised learning that one of my mentors, Dr. Shamim Namati, put out in Critical Care Medicine in 2018. And it was at this point in 2018, there wasn't a lot of people that were able to say they could use any kind of machine learning to generate these predictions of who was going to become septic. And using a very large data set composed of both Emory ICU data as well as data from Boston from the MIG-3 database, and taking 65 distinct input features, things like, again, labs, vital signs, some waveform data that they had available, they were able to predict sepsis about 4 to 12 hours prior to onset. And if you're curious what this kind of looks like, again, on the machine learning side, right, this is a supervised model. So there is labeled data, input data, right? Again, demographics, vital signs, et cetera. And there's the output data that's labeled too. In this case, it's sepsis. The model then gets trained and it generates predictions on that data. And then using a new data set, the researchers at that point were able to evaluate the model performance to see how good this model could predict sepsis in the ICU 4 to 12 hours ahead of time. And you can see here with a fixed sensitivity of 0.85, the model did pretty darn good at predicting who would develop sepsis within a very heterogeneous patient population. And again, this, I think, got a lot of people very, very excited about the potential of applying these models to the bedside. So what were some of the takeaways from this? Well, it was retrospective and it was observational, which has its, inherent limitations there. But still, Dr. Damati and his team were able to show impressive test characteristics of this model to predict sepsis in the intensive care unit. Importantly, too, is for the models or for the patients where the model said they were becoming septic, but the model was wrong. These patients also had a very high mortality, suggesting that at least if there was the potential for some clinician to intervene by heeding the advice of the alert, that there might be the ability to improve patient outcomes. But importantly, this paper did not yet address the implementation and the generalizability of these models at different institutions. And I think as someone that's been in this domain for the past, 5, 6 years, there are a number of barriers that it comes to machine learning in clinical care. What I've seen anecdotally is that people usually fall into two camps. You have some that are really excited about this and want to do this at all costs. And then you have some that are inherently going to be a little bit skeptical. And this is a tweet. This is 2021 that just kind of illustrates a pretty well-known social media personality that was a pediatric intensivist that wasn't really too keen on, a lot of the technology that was being pushed at her institution. And this is something that we studied. We put out a web-based survey to kind of identify barriers to machine learning in clinical care. And it was focused more at critical care doctors. But what we found, and this is not surprising to me, is that a lot of times these clinicians were unfamiliar with the approaches. They were concerned about high false alarm rates. They were very, very worried that this would significantly impact their workflow. And they also highlighted, at least in their responses, they had a lot of concerns about the transparency of results, meaning that they didn't want to take something from a black box, but they wanted some kind of interpretability of why the model was saying what it was. And a common theme, and we're going to talk about this more and more, is there hasn't been a ton of high-level clinical evidence that supports the use of these at that time into clinical care. And it's something that, particularly for physicians that are evidence-based, like what we see at UCSD, these concerns get brought up time and time again about, hey, where's the data that me using this is going to improve the care of the patient I have? And this is something that we've addressed, at least with some of the studies we're going to jump into. I think something else to mention is if you are a clinician and you work at an institution that has EPIC, you've probably heard of the EPIC sepsis score. And this is something that was, the EPIC sepsis score was put out, I want to say probably 6 or 7 years ago. It was developed and validated at 3 institutions. And then EPIC effectively said, hey, if you're interested in using this, you can take this sepsis model and use it in your patients. And there wasn't a lot of prospective validation about how this model would do. And this is something if you do follow, kind of what we're doing with the Jacobs Center for Healthcare Innovation, this is Dr. Karandeep Singh. He's our chief AI officer. And what he did when he was still at Michigan is they actually took a look to see just how good the EPIC sepsis score did. And it's actually fascinating and a little bit disheartening just how poorly this model performed at Michigan, where Dr. Singh was. Of the patients that had sepsis, which was roughly 2,500, the EPIC sepsis model far underperformed what it was reported with an AUC of 0.63, so not much better than a coin flip at predicting who would develop sepsis for their patients. Importantly, it also missed about 1,700 patients, which is a big, big issue for a very time-sensitive condition, such as sepsis, where those first few hours can be absolutely critical. And then, unfortunately, too, on top of that, the EPIC sepsis score generated a lot of false alarms. And this goes back to what I told you from some of our prior survey data, is that a lot of times clinicians are very, very worried about these interruptions in their clinical care. And so this really got the attention of a lot of people throughout the country. And I actually am willing to bet that part of the that Dr. Singh's kind of rock star status was largely shot up because of the study that he put out, just highlighting again some of the pitfalls if these models are not properly trained and not properly implemented and not validated before going into clinical use. So what are some of the takeaways? Well, what was touted from Epic, which is the largest electronic health record vendor in the United States, is it really underperformed what it was how the group there said that it would perform. I think it also serves as an extremely important cautionary tale that even if you have a fantastic machine learning model to predict something or do some task at your institution, that external validation becomes absolutely critical before widespread use because you can run into a similar situation. And unfortunately for Epic, I think they took, it was a little bit of a black eye for quite some time. And certainly in a lot of the online periodicals evaluating health IT, this was kind of the talk of the town for quite some time. So unfortunately for them, it just didn't really kind of live up to the expectations and honestly the excitement of using a tool to predict something like sepsis. So where can we go from there? And how can we use this technology then to improve patient-centered outcomes? Well, this is a piece we put out in Critical Care Medicine in 2023, where we outlined some steps that we thought would be quite useful in terms of how we can actually get some benefit from using these machine learning models into clinical care. Some of the things that we highlighted, and again, we're going to discuss most of these here, but data augmentation is absolutely critical. You can think at the basic level that if you have garbage in, it's going to be a garbage out type prediction from any kind of model. But the better you're able to get your data, and this is something that we do have some of our team is working on, even when the model thinks it's missing data, to recommend that it be generated through either asking our nurses to get more vital signs or even send off labs. That data augmentation can really inform the predictive model to become more and more accurate. Generalizability, as you just heard from the EPIC sepsis score, is something that must be addressed. And I think what we're realizing more and more of is that the best model is the model that's been trained on your own data, rather than taking a general model developed from nationwide data and trying to ship it to your shop. Implementation science is something that's absolutely critical. That's been, somewhat of a focus of my K-23, is how do you get someone to take this model and actually use it and derive value from it, rather than trying to get out of it as quickly as they can, particularly with an increasing number of alerts that really kind of run through our electronic health record. That competition, so to speak, for the useful ones that inform care is something that studying it is quite important. One thing you heard me talk about earlier, right, is it's evaluating prospective studies to assess the benefit of these models. That's something that is inherently difficult. And in fact, I think it's a little bit limited because funding agencies like the National Institute of Health seem to be more interested in the development of models rather than the evaluation of mature ones. And I actually remember when we were getting ready to submit my K-23, probably I think about a month or so before I submitted it, we sat down with the program officer and went over what I was thinking about. And she goes, Gabe, you realize that we're not going to fund anything that has, kind of evaluating a mature model. It's like, oh, yikes. So it is something that I think, needs to be emphasized with our, is that the prospective evaluation is something that our funding agencies do need to take as something that's very, very serious. And something that we're not going to talk too much has to do with the appropriate governance. This is something that's gotten a lot of attention. And I do want to, applaud our colleagues here at UCSD that are really leading the way when it comes to AI governance in healthcare. Something too, right? This is a nice little figure that I think gives a nice layer, or different layers about how to approach these models and AI in clinical care. And again, it's a multi-dimensional approach. I think the mistake that I see is people focus only on the artificial intelligence, not realizing that what goes into the model is going to be the data, and that the sanctity of the data will often dictate how good the AI model is. But then we also have to think about that policy layer, how people work with that model. And something we're realizing more and more now, right? What are the financial and legal constraints that go with this? And a lot of this is still not clearly defined, right? And then how do our clinicians actually use this clinical decision support to actually do what they want? And then finally, how can we use the model to generate data when it's appropriate, right? This is something that isn't really described much, but I think it's a very, very logical step. If the model doesn't have enough data to make a prediction, it might make more sense that the model said, hey, I'm missing some data. Is it worth at that point getting vital signs, so to speak, or for instance, from a patient to see if you can use that to augment the prediction rather than putting out a somewhat uninformed prediction? So some examples, and again, this is where we're going to start diving into some of the work that we've done here about how we've kind of built up these models to get them to the bedside. And the first piece that I want to highlight, this is something that we put out in 2021. You can see the first author here just left us for industry, but it was a real pleasure to work with Dr. Supreet Sashakumar. And what he did with us is that he really worked to kind of come up with a way that we could decrease model predictions for data where it just didn't make sense for the model. And probably the best way to think about this is in the title of this paper right here, where it's Artificial Intelligence Sepsis Predictive Algorithm Learns to Say, I don't know. And in effect, what this is trying to do on a conceptual basis is that if the model itself does not recognize the input features based on what it was trained on, it's not going to put out a faulty prediction, but rather withhold that prediction. And I think this is quite logical, and it goes back to, honestly, what you hope that, that our physicians do when they encounter something where they don't feel confident in making a decision. They can recognize that something is outside of what they've seen before and said, yikes, I don't know the answer here. I'm going to take more of a look into it. And that's exactly what we were able to do here with this sepsis conformal set, where if a new patient encounter came in and the data just didn't really kind of fit within there, that data was rejected from making a prediction. Now, how did that do in terms of the ability to improve the prediction? Well, as you can take a look here on the left, You have the AUC of three different models. The one in question that was developed, the model was called Composer. And this outperformed two different models that were also kind of used within this series of investigations. One of them may or may not have been the EPIC sepsis model, but you can see here that by using this conformal prediction to reject patient encounters that didn't quite make sense to the model, we were able to generate the best AUC, but importantly too, and for clinicians, what they probably care more about would be to decrease the number of false alarms per patient per hour. And it goes back to some of that survey data that I showed you earlier, that what people oftentimes care about, right? If the model is fine all the time and it's wrong, you lose trust immediately with that. So really minimizing this through conformal prediction, we thought was a huge win. Now, what else have we done in this domain? This is something that Dr. Shamim Namadi was kind enough to kind of help me as I was submitting my K-23, would be some strategies to improve generalizability in other institutions. And like I said earlier, a lot of times models that are trained on data from their own institution are going to outperform probably anything else that's generated from a large nationwide data set. And what we wanted to see here was really twofold. One was, could a machine learning model predict patients that came to the emergency department with sepsis that were at risk of developing delayed septic shock, which is what we see a decent amount, and the results can be catastrophic. But on the technical side, the twist would be to see, could we use something called transfer learning, where we effectively fine-tune the model? Could we use that to then improve the model performance at a second institution? And just as an example of kind of what we did here, right, is the initial machine learning model was trained with I think with this was probably about 45 input features to predict septic shock using UCSD data. That was our development site with over 135,000 patients. And then once we had that, we then took that model with the hyperparameters that were selected based on what we thought made sense at UCSD, and then we went with Emory data and we fine-tuned that model using data from Emory. And what we are able to see right here is going to be the model performance. First, showing that what we were able to do to predict delayed septic shock was actually quite impressive, particularly because this was 24 hours after the initial development of sepsis, which is increasingly difficult as you get further and further away. But what we are able to do using Emory is with this approach called transfer learning, where we fine-tune the parameters based on Emory's data after a model had already been built at UCSD, was to show that that also significantly improved the model's AUC at Emory. So it's, again, it's a nice instance of something that you can do if you're thinking about taking a model from one institution and transferring it to another place. And again, all retrospective data here, but certainly compelling. Something else along the way that we've really kind of worked on has to do with what we call multimodal data. This is what the second aim of my K-23, as you can see the pink Fitbit right here. But really, how can we improve predictive abilities through the addition of additional data sources? So what are some prime examples of this? Well, we'll talk a little bit about clinical notes and some of the work that's gone on there. But some of my colleagues are experimenting, right? What's the added value of adding in some kind of chest X-ray or chest CT into predictive abilities? Like I said, my interest is in how we can use wearable biopatches to better predict adverse events from sepsis patients. But again, this is something that's still experimental, and it takes a significant amount of work to kind of make sure that the data comes in and is fed into a system that can then be allowed to make these predictions. So just some examples of some of the stuff that we've done in this domain. This is a paper we put out just last year where we took a look using all of us patients that UCSD has put quite a number in to see if we were able to use the wearable data from people that had Fitbits on. Could we predict who is going to get readmitted up to 90 days out by augmenting a baseline machine learning model that was dependent on basic patient features like age, sex, demographics, lab results during their hospital admission, discharge vital signs, and what's the added value then of abstracting data from a wearable device. And not surprisingly, there was a significant increase in the model's predictive ability after the inclusion of wearable data from the Fitbit. Now, this is something that, again, when we took a look at these patients, they had an extremely high compliance with their Fitbit. And I don't know if anyone on this group has worn a Fitbit, but if you're like me, you probably lost it within the first few days of doing it. And that's something that we're seeing right now as we go through and enroll patients for some of our prospective data, is that compliance with these wearables can be quite challenging. But needless to say, we were able to show that the addition of the data from a wearable device significantly improves the predictive abilities, regardless of the model that's used. And what we here are just two different machine learning models, but the AUC bumped up by about 0.15 to 0.2 by using wearable data. Something else that we've experimented with is, using data sources that are a little bit outside of the typical predictive model, and we got very interested in how the social determinants of health could improve predictive ability for sepsis patients. And this is another study using the All of Us data set, where we took advantage of the fact that they have extremely, extremely detailed surveys. And what we wanted to ask the question was, can the social determinants of health data that patients provide via these surveys, can that data improve the ability to predict who's going to be readmitted within 30 days? And what we were able to show is that the machine learning model with the social determinants of health data had a significant increase in its predictive abilities, where the AUC went up predicting an unplanned 30-day sepsis readmission from about 0.75 to 0.08, a very significant improvement, which is something that is not that difficult for us to do here at UCSD, because a lot of this data is now being abstracted into our patients' records. It just isn't usually accessed for this type of purpose. So what we're going to talk about right now within this setting of, some examples of retrospective data is what we've done here at UCSD to kind of bridge what we call this clinical implementation gap. And this is something I think is fascinating. If you think about how long from when we know something could work to when it actually gets used in clinical practice, on average, it's estimated that takes about 15 to 17 years. And this is something, at least I'm very proud of, some of my mentors and the team that we've been working with, is that we were really able to kind of cut this time down from what we knew we could do with some of the examples that we showed you earlier to actually bring this to the bedside. And this is something that's been highlighted time and time again in any number of journals, that really this development to implementation gap in clinical artificial intelligence is really through the roof, to the point now where this was published in Nature Medicine in 2021. I feel like it's become such an old fiddle to hear this term, that everyone is really, really excited about the prospective data from these models being used in clinical care. So here's what we did. And I do want to give a special shout out. This is Dr. Aaron Bucina. He just got his PhD with our group. I don't see him on the call, but Aaron spent a lot of his efforts kind of working to develop the infrastructure to actually make a lot of this work possible, and was a fantastic collaborator as we started to bring some of these models to the bedside. So kudos to him, and he's, I think, really a rising star in this domain. So this is kind of a flow chart, so to speak, of what we did here at UCSD when it came to bringing some of these AI applications to the bedside. So the first thing is we wanted to make sure that we had a great model. Unfortunately, I work with some of who I consider some of the best in the business, so to speak, Drs. Namati, Dr. Bucina, about something that the composer model that I just showed you, that I still maintain is probably the best model that I've seen that's been published. But what we really wanted to focus on is bringing an implementation strategy, working within a broad interdisciplinary team to bring this model to the bedside, and then importantly, to study how it actually impacted patient-centered outcomes, which again, I would maintain is probably the ultimate goal now at this time with a lot of these AI applications. This is a little bit futuristic, but if you are curious about some of the ways that this works, let's say that you are at ACTR right now and you check into our La Jolla Emergency Department. As soon as you check in, data is actually abstracted from the electronic health record, goes up into Amazon Web Services, where hourly predictions and data are updated if you are at risk of developing sepsis. This is then shot down back into Epic, where we're able to alert our end users. if sepsis is possible. Now, there are some things here that are a little futuristic. We are not yet grabbing stuff from, say, ventilators, but I think that's not too far off in the future that we'll be able to have some really fantastic stuff. But again, what I want to highlight here is this is something, again, that I think makes UCSD special. It's just this ability right now to get data out of Epic, allow it go to Amazon Web Services to do these predictions. And at least speaking with other physicians across the country, they're absolutely floored that we're able to do this in such an efficient manner. So again, we talked about supervised learning, unsupervised learning. Again, the model that we're using, Composer, is a supervised learning deep learning model. We take now 150 or so different variables that we use to generate a prediction where the model was trained to identify patients with sepsis. And then one thing that we did here that I will never forget, the 9-month period where we had what we called a silent trial, where we would sit down every week and we would actually go through cases where the machine learning model would predict who was likely to develop sepsis. And at that point, we weren't letting the end users see the result, but merely we were going through and evaluating if the model fired appropriately. Was there something that we could do better in terms of some kind of suppression to the alert to make sure that it was beneficial to our end users? And indeed, there was many meetings about this over this 9-month period, but I think it actually was quite useful in kind of optimizing the model, so to speak, for our workflow within UCSD Health. The implementation model that we chose to go with was called the EPIS framework. This is something that I got introduced to on my ACTRI pilot grant from the Dissemination and Implementation Science Group. And largely what we wanted to do is we started a few years before actually going live to identify a clear use case scenario. And for me, what I thought running our hospital sepsis program is we do great with sepsis where it's obvious, right? The patient comes in, they have a high fever, they have a low blood pressure, their heart rate is very fast. That is what I call monkey sepsis, where you don't need really any intellect to kind of identify that. But rather these cases where it's a lot more subtle and the ED providers do not initially start management. We then went through and started reaching out to all the appropriate stakeholders to make sure we had buy-in. And this ranged from the hospital C-suite down to our bedside nurses. And once we felt that everyone was good with the approach, the implementation was good, we went live on December 6th, 2022, and we continued to follow the model to see how it did. And I remember when we went live, I was like, yikes, we're finally here after all this work. If this fails, I've really messed it up. And it was a little bit frightening to kind of see as the data started coming in and see how our sepsis patients were doing. So what did we do to study this? Well, we weren't able to do a randomized trial. Randomization is exceedingly difficult, particularly for small units like our emergency department. But what we are able to do is probably the next best thing through forecasting about what the anticipated mortality was going to be based on historical trends. And so we were able to grab 6,217 sepsis patients. And the exposure that we had was a best practice advisory, the pop-up that was facing our nurses in the emergency department that would alert them if the patient was at risk of developing sepsis. Now, the forecasting that we did was something that was quite fancy, and this is why I was glad that Aaron was working with us on his PhD. But he went through and used causal impact analysis with some time series to actually see the impact. And the primary outcome we chose to look at was survival. That was our primary outcome, which I would argue is probably the one that patients care the most about. On the regulatory side, we talked about, how this impacted our sepsis bundle compliance, since we have to report this to the federal government, and there's financial reimbursement linked to that. And then we also wanted to see some intermediate outcomes, like organ failure at 72 hours, to see if any of these interventions we were hoping would happen from using the model would actually prevent organ failure. If you're curious about what the best practice advisor we had go up to our nurses looks like, this is what it is. We've had a few modifications since we went live in December 7th, 2022, but this is largely what we have right here. You'll see just a few things to highlight. We're actually the first best practice advisory to have a secure chat pop up right there. And to this date, it still says secure chat the physician and Dr. Gabe Wardi, because I really did want to stay on top of this if there was any questions to make sure our staff felt supported. This is also something that looks a little trivial to kind of put this out there, but there was a tremendous amount of back and forth from our bedside nurses that were the ultimate end user here about what would be most effective for them. We also wanted to study how people use this alert, and something that we've seen throughout our hospital is that oftentimes when a BPA goes off, the first response is, how do I get out of this? Get me out of this. I do not like this. And that is obviously a failure when it comes to the whole reason of having the best practice advisory to inform care. And what we're able to see here with how our nurses responded here is actually over half discuss this with the physician, which is a tremendous win. And what I was even more excited about is the dreaded, I'm just going to X out of this because I don't care, was less than 10%, which I think is a huge, huge win. And again, I think it's a tremendous kudos to a lot of the nurse educators that we had that were working with us as we were going live with this. Now, this is where we got very, very excited, is when we actually took a look to see how our mortality changed after we went live with this. What we were able to show is there was a 1.9 absolute decrease in sepsis mortality, which corresponded to a 17% decrease, a relative decrease in mortality during the intervention time period. And just to put that in the context of sepsis interventions and therapeutics, there's probably been about 180 or so different therapeutics that have been proposed as agents that can improve sepsis outcomes, and all of them have failed in the past few decades. So the fact we were able to show some improvement at UCSD using this was extremely, extremely exciting. We were also able to show that helps the, kind of the reporting and the quality side is that a potential mechanism of why we saw an improvement in outcomes had to do with an increased use of our sepsis bundles that, again, I think makes sense in most patients, but is not always definitive. But we saw an increase there. And we also saw, probably most compelling in terms of a mechanism, was a decrease in the time of antibiotics for these patients when the nurses alerted the physician about the possibility of sepsis. And time and time again, what we've seen is probably the best way to improve outcomes of sepsis patients is going to be those timely antibiotics, particularly for the sicker ones. Along the way, we were able to see that we did have a decrease in organ failure at 72 hours, which was a nice intermediate outcome that we thought was important at looking at. And we also saw a trend towards decreased ICU length of stay and ICU admissions in the intervention time period. So overall, very, very exciting. We also went through and got, survey data from our nurses and physicians about how they felt about this model. And getting survey data can be quite painful. Unfortunately, I was able to recruit a graduating resident who needed a research project, but we were able to get the perceptions of 117 nurses and physicians that work in our emergency departments to see how they felt about the tool. And about 80% or so had either a favorable or a neutral perception of this. Now, what gets interesting is who derived more benefit from it. We found on average, the nurses found this was more useful, but also the younger generation, meaning that people that were further along in their professional career saw less benefit from this. And I'm not sure if they were just not willing to take on a new technology, or they had better clinical gestalt and really were able to kind of hone in on these cases a little bit better than someone that had just finished their residency training or someone that was a first or second year resident. And hopefully we get this published soon. I think it is very, very soon to come out. Something else that we were very intrigued by, and this is that we're still investigating right now, is when we were able to investigate further this decrease in mortality, what we noted is that Hillcrest, our Hillcrest campus that has a much higher underserved proportion than La Jolla, actually had a significant decrease in mortality compared to La Jolla. And there's multiple hypotheses why this might happen. Some of the ones that are certainly important and worth thinking about have to do with La Jolla has a high cancer population, and oftentimes sepsis can be more of a sign of end of life. But what we're very intrigued by right now, and Aaron and I are going through and running the data, could this model be an actual way of decreasing health disparities? And I think it makes sense if you could think about it this way, is that people that have less healthcare to begin with, they're higher risk of having an adverse outcome. So could this model kind of help catch these patients a little bit early as they come through our emergency department and potentially get these treatments started? So again, it's something that we're driving into a little bit further, but I think it's a very, it's a nice little benefit, so to show, right, that we're minimizing some of the disparities, particularly the economic ones, by at least with observational data. So what are some of the next steps? And this is what we're going to conclude with, because I think this is where it gets very, very exciting. Anyone that's been around in the past year has heard about the generative AI revolution, right, that's going on. And that's something that we've been investigating, how we can use this to improve patient-centered outcomes. Something that I'm very, very excited about is how we can use biologic data in addition to the predictive model to really kind of improve the model's performance. And then something that, Dr. Namati was just awarded was a very significant amount of funding to explore how this model could perform at other UCs. So one thing, and this is largely, I think, where we're going to finish in the next 3 or 4 minutes so we can take any questions. But this is something that I think is very, very exciting right now, is that we're able, through the infrastructure set up by Dr. Aaron Busina, Dr. Shimon Namati, is actually to ingest clinical notes and use those notes at this point to actually inform the prediction. And very specifically, we are pulling data from the emergency department and asking a large language model this prompt, going, you are an emergency department doctor. Your task is to identify if sepsis is present in the current admission. Think step by step and provide your response in the following format: sepsis, yes or no. And what's fascinating about that is by ingesting these clinical notes that our nurses and our physicians write, what we are able to do is actually show that the model is able to significantly increase its positive predictive value by removing some of the false positives that have plagued the model for quite some time, notably things like gastrointestinal hemorrhage, bad heart failure, substance intoxication are very, very difficult for a lot of models to kind of tease out from sepsis. But by ingesting these clinical notes, where it's very, very obvious that, let's say, someone is reporting that they are spitting out blood, both from their mouth and their rectum, which explains every single abnormality. And while that might look like sepsis with vital signs and labs, it certainly to a provider looks nothing like this, like the two. And to take that data and actually use it to improve the predictive abilities is something very, very exciting. Something else that we're doing right now, and this is, again, working with Dr. Busina, is that we are working to automate how we report our sepsis quality metric. And this is something that every month that I spend too much time is going through and manually reviewing these cases to see how good our providers are when it comes to the sepsis care that they have. And the question that we asked was, could a large language model approximate an extremely complex quality metric that takes 65 different steps. And the preliminary results were that there was agreement of about 90%, which is mind-blowing, considering that humans do not have anywhere near that same agreement. And one thing what we're going to finish up with right here is how we're actually using that at UCSD right now. And so one thing that we just started was a randomized quality improvement initiative, where what we are doing is every day there's a report of how the sepsis quality of care was for the 50% of emergency medicine attendings that were randomized to the intervention. We then send them an email to let them know about the quality that they had, as well as any recommendations for any reasons that they did not comply with our hospital sepsis quality rules. And we either give them the opportunity, if there's documentation that can be fixed, to work on that, or what I'm more excited about is how is that actually impacting their behavior. And this is something we've been doing this for the past probably about month and a half or so ago, or we started this that long ago, and we're able to see right now actually is that there's a significant improvement in those that are actually randomized to get this near automated feedback from the large language model, just with a little bit of, kind of inserting me in that domain to make sure that people take it seriously. So to end this talk, we're going to go back to that story I told you of me finishing my fellowship in 2017 and kind of taking over our hospital sepsis committee. And what we've been extremely excited about is just over the years, really kind of watching this continued decrease in sepsis mortality. And most recently, as I was like, yikes, I think we've kind of optimized all that we can do. Really, the implementation of these machine learning approaches, I think, have been instrumental in continuing to shoot us off to some of the best outcomes of sepsis patients in the country. So with that, we're going to stop. And if there's any questions, I can take them in the last 5 minutes. But thank you all so much for tuning in to hear this.
Gabe, I just want to pop in and say thank you. That was an outstanding presentation, summarized many years of work by a large team, and your leadership has been incredible and invaluable, not only in the work itself, but the outcomes assessment. So thank you. Thanks for a great talk, and thanks for the continued efforts. I'm super excited about the work you're doing in the emergency department on scores with LLM, and I'm also super excited about our randomized post-op sepsis efforts and opportunity.
Thank you. And again, just to emphasize, right, this truly has been, there have been so many individuals that have been, involved with this work. And it really spans, from our, again, world-class data scientists to, the kind of the, what I was, in 2018, which is kind of the fresh body that thought this was cool. So.
Gabe, it's Jeff Esco. I have a quick question. It may be a bit naive, but why is training this on the local data set so important? I mean,
yes, you're asking this is something perhaps Dr. Longhurst is more passionate about than I am, because conceptually, right, you could think, right, if you had a nationwide data set, right, that the model that would be developed would probably outperform anything else. And that just oftentimes hasn't been the case. And a lot of times it comes down to some very basic things like how frequently do we do vital signs at UCSD versus Sharp Memorial? How frequently are labs being checked? And all that stuff, well, it seems like it's not a big deal for us. That's where a lot of times these models, right, when they're trained, they're expecting to see stuff at specific times. That can have a pretty big impact. The other part of it too, right, is going to be local patient population, right? What makes UCSD's patients distinct, right? Well, we probably see more cancer patients than, let's say, someone that's working at Sharp Memorial, where they have probably more of a community type feel. So by having that model that's trained on the population you're taking care of, with the nuances in clinical care, and the way the timing and the frequency of a lot of the input features can have a pretty big impact. But I don't know, Dr. Longhurst, if you have any other thoughts on that, but I know that's something that you've been quite excited about, kind of making a big point, but I think a lot of it comes down to that.
can you
Yeah,
use, sorry,
go ahead, Jeff.
Go ahead.
I was going to say, I agree with Gabe, and it's really a big national discussion right now about, can we use these AI models developed on national data sets, or do we need more locally developed models? And, Gabe's experience and outcomes, I think, argue for the latter, but the jury's still out.
So my follow-up question was, if you trained it, let's say on a data set, generated it through scripts, right? Or through another hospital system. And then can you use AI in order to figure out what were the differences in the ways that the patients were treated to kind of come up with a universal assessment from a clinical perspective?
Yeah. So I think you're getting at almost, the holy grail, right? And I think that's where, a lot of these approaches, we talked a little bit about some of the generalizability challenges. But again, we gave you one example of, what's called transfer learning, right? Where the model is made at one institution and then you use, that baseline, right? That's been, where a lot of the weights of the the hyperparameters have been, kind of put at a starting place, so to speak, to kind of optimize at a second clinical site. And I think, those strategies about how we can use this to best optimize these models at different institutions is going to be ultimately extremely important, because it's computationally quite expensive to develop some of these models, particularly some of these weights of the hyperparameters that are used. So for a small place, let's say El Centro, for instance, right, that doesn't have a lot of patients, right, what would probably make sense, to get to your point, right, about this generalizability, would, hey, something built at UCSD and then fine-tuned on their data would probably give the best approach, rather than taking our model, sending it out there, or honestly, probably something built from nationwide data too. But again, some of the jury is still out on this. All right. Well, I think if there's no further questions, I thank everyone for being here. I know we're a minute over, so I appreciate your time.
Thanks, Gabe.
Yeah.